This is the next set of flashcards, or actually, this is the first set of flashcards where we look at changes in diabetic eyes. So the first change that's shown is this, and this is late evacuation of the posterior iris, which is caused by accumulation of glycogen due to hyperglycemia. So of course, it's going to be PS positive. This is the lens. We can see that the front of the iris is flat, but new vessels are not easily seen. Here is another example. Sometimes it can look a bit messy like this, evacuation. And again, notice that this iris is looking particularly flat. Moving on to the next slide. All these come with a multi-choice question that is an example of what the students might get when they come to the exam. So I've given an example of that there might be either a picture or there might be a sentence that describes what they see. And then they will be asked a question like this: what is the most likely cause of this histologic change? When you come to look at these slides on the day, I will have put in a gap here so that there is the answer hidden until the next slide. Okay, let's have a look at the next picture. All right, so this is the cotton wool spot, also known, which is part of the, this is a cytoid body, which is part of the cotton wool spot. So cotton wool spots are focal infarct of the retinal fiber layer caused by retinal microvascular occlusion. So orienting yourself to this picture, we've got the RPE, we've got the probably the photoreceptor layer, the outer nuclear layer. The inner nuclear layer has been disrupted. There are no ganglion cells, and these are the cytoid bodies. And this is the kind of fluffy look that forms the diabetics, that forms the cotton wool spot. Okay. So if we go now to the multi-choice question that is associated with this, multiple cotton wool spots, what would histological examination of the retina show? Okay, and it gives a variety of things, and the answer, of course, is infarction of the retinal fiber layer. Okay, so here we go. This one I've included a, um, a nice picture here, so they'll get a bit of a clue as to what's happening. But let's have a look at the retina here. So we've got the choroid here, the RPE, the photoreceptor layer, the outer nuclear layer, the inner nuclear layer, no ganglion cells. And here in the nerve fiber layer between the inner and outer nuclear layer, so this is the outer fiber layer, we've got an accumulation of macrophages together with lipid and protein. And this is what is a hard exudate, and it's caused by chronic retinal vascular leakage because diabetes causes loss of pericytes and endothelial dysfunction, leading to increased vascular permeability. And it's usually here in this outer nerve fiber, also known as the outer plexiform layer, and it appears as these white hard streaks in the eye. And so the next page will show, again, a typical MCQ. So this, sorry, slightly out of focus photo here is another example of a hard exudate, showing the difference that you might get with different staining qualities. Note as well here we have got a subretinal exudate here, but yeah, so this is another hard exudate, and okay. So this is the key points that they have to come away with: that hard exudates are lipid leakage from incompetent vessels, and cotton wool spots are ischemic axonal injury. So moving right along with the diabetic eye, I'm sure that this needs no explanation because you will have seen it in other organs of the body. So we've got thickening of the choroidal vessel here. We've got the RPE at the top and the hyalinized diabetic-related vascular thickening here, where chronic hypoglycemia causes persistent high blood glucose, blood glucose, and there is lots of theories about why this happens, and the registrars will be able to tell you about it. But I think that there's endothelial dysfunction for a wide variety of reasons: basement membrane thickening, deposition of plasma proteins, and then there's hyaline atherosclerosis of the vessel. The next slide will give a multi-choice question about this. Okay, and then we come to the dot and blot appearance in retinal pathology. So this is due to diabetic microangiopathy due to loss of pericytes and endothelial damage because of the hyperglycemia. So the blood accumulates here in the plexiform layers, both the inner and outer here. And the deep intraretinal location gives rise to the blot hemorrhages. And here in the outer nerve fiber layers, we have these flame-shaped hemorrhages. Okay. So flame hemorrhages are nerve fiber layer bleeding, and dot and blot are the deeper bleeding. And then that's followed by another MCQ. Okay, and then we've got the other posterior feature here of diabetic retinopathy, which is neovascularization. Okay, so we've got this nice little chain of vessels that's emerging from the anterior, this like microaneurysm in the anterior retina. And this is mediated by VEGF in response to chronic retinal ischemia. And chronic retinal ischemia happens because of the vascular changes in the diabetic eye. Okay, and next. Okay, and this one here. Okay, so what we've got here is the optic nerve head, and we've got this retina has been lifted off, and then we've got this subretinal exudate. And what's happened here is a neovascular membrane has formed and contracted, and all these are abnormal new vessels as well. The retina has been pulled off by the traction. We also have traction pulling the optic nerve forward here. Okay. All right. And then finally, the anterior part of the eye. So you'll be able to see here that this is the iris with the not really prominent neovascular membrane on the anterior surface, and ectropion iris is adherent to the posterior cornea, and the trabecular meshwork is here. So this is classic neovascular glaucoma. Okay, and other things that you might see in diabetic eyes are retinal burns. So when the retinal laser therapy is used, it causes essentially these little micro burns to the retina. It adheres it to the RPE by gliosis. You can see some RPE proliferation here. There's loss of the outer nuclear layer and the photoreceptors here, but because it's peripheral, people don't usually notice it in their vision. And the idea is to tack down the retina so that the neovascular membrane we see here does not pull it off, and therefore the person doesn't lose all their vision immediately. And then there's the final MCQ, and that's the end of that slide set. Thank you.